Hi everyone and welcome back to the Old Skhool RN. For those of you who are new to the channel, I'm Deb. I'm a registered nurse with over 35 years experience in the NHS, in intensive care, emergency nursing, clinical research and management. I've also worked in the private sector and I currently do, even now. So today I'm going to be looking at a research study that, in my opinion, raises one of the biggest questions about the future of community nursing. And I'll just put in case anyone's watching who has anybody who is in a terminal phase of illness, this is what I'll be discussing today. So this is called an INDIGO study. So at the moment, it's just being researched, so it's not being tested out yet at all. And INDIGO actually stands for investigating the use of intranasal diamorphine and of pain and anxiety and freeing nursing resources in palliative care. It's quite a mouthful. But if you look up INDIGO in capitals, it will come up on Google and you can look at that in more depth if you wish. So I want to be completely fair about this. I think the researchers involved in this study are trying to solve a genuine problem. It's patients at the end of life who can suddenly experience like severe pain or distress when they're being cared for at home. This is an end of life issue. Nobody wants a patient waiting for symptom relief. And the aim of this study was to reduce that pain and suffering because of a lack of nurses. Now, that deserves respect, but as I read through the study, there was a few things I was asking myself, such as, how did we get to this point in society that we need such a study? When did we reach the point where the answer appears to be training relatives to administer controlled drugs? What happened to district nursing? Because when I trained in the 1980s, it simply wasn't how community nursing worked. So today I'm going to explain what this is all about, why it's being undertaken, and why I believe it's opening up a wider conversation about what's going on in the NHS and community itself. So let's have a look at the facts. What's the INDIGO study? This INDIGO study is funded by the National Institute for Health and Care Research. I know this well because it was part of what we did as research nurses. Its purpose is to investigate whether people in the family carers, can safely administer intranasal diamorphine for severe pain. Intranasal means sniffing up the nose, so a squirt up the nose. And intranasal midazolam for anxiety and terminal agitation for patients who are receiving palliative care at home. So instead of waiting for an injectable medication or a pump to be refilled or whatever from a community registered nurse, this can be administered by carers themselves or family themselves. Now, medication can be given in many forms. However, its effectiveness needs to be known. And the medication that's given through the nose, through a nasal spray, is effective because the nasal lining contains lots of extensive blood supply and blood vessels. That's why people who take certain substances use their nose, because for that very reason. And certain medicines are absorbed very, very quickly. Now, this means that symptom relief can occur much sooner than waiting for a member of staff, a registered nurse, to come and complete the pump or give intramuscular or intravenous medication. Now, the study is currently a feasibility study, and researchers aren't trying to change NHS policy. They're just asking the questions. Is this something that can be done safely? Can relatives be trained properly to do this? Would patients and families accept it? Should there be a larger national trial to evaluate this? And I think as a ex-research nurse, these are reasonable questions to look at. So let's have a look at why this research exists. Why has this study been developed? Well, apparently some families, it doesn't say how many from what I've read, are waiting around 90 minutes or an hour and a half, sometimes longer, or up to 90 minutes for a district nurse to arrive after calling for help. So imagine a family member sitting by the bedside of someone they love. They're dying, they're in pain, and perhaps they're becoming restless, anxious, distressed. they're having a terminal agitation state. You then go and phone for help as a family member, and then you wait and wait and wait. And that can feel like forever. And researchers have quite rightly asked, can we do something about this sooner until an expert is on scene? So from that perspective, I completely understand why this study exists. But the question that immediately came to me was, why are families waiting up to 90 minutes? Because 30 or 40 years ago, this would have been a completely different conversation, if it ever took place at all. And let me tell you why. We used to have GPs and a community team. They did home visits. GPs especially, and the nurses, knew their patients, so being left to cope as a family wasn't an issue. We had district nursing in full when I trained, and GP home visits. So I qualified as a registered nurse, my 3-year RGN course in 1985, and district nurses were the most respected members of the NHS. They knew every GP, every health visitor, social worker, and every family that they were caring for in their region. They weren't simply carrying drugs or syringes or doing mediated care. They were highly skilled registered nurses in community with extra qualifications. They assessed their patients, did pain assessments, gave medication, managed wounds, supported long-term chronic illness like diabetes, and visited people after surgery. They cared for the terminally ill patients and their families, and some even attended funerals of their patients. They recognised deterioration. They knew what stage that patient was in terminal decline and when to be ever more present. They worked closely with GPs, and the GPs would call in and know their patients and the families too. So if Mrs. Jones had cancer, the district nurse already knew about it because of the communication from the hospital. She also knew that lady's husband, her daughter, her neighbours, her wider family. She knew what equipment would be needed, what anticipatory medications had been prescribed, what symptoms were likely to develop, and when. She didn't respond to a crisis. She knew what was going on. It was an anticipated role. It was an experienced nurse. So this is what skilled nursing is about: theory, practice, and experience. And community care is at the heart of that. And families, they trusted these nurses completely, usually on first name terms. So what's changed? Well, today's district nurses are no less skilled, if anything, but their patients are far more complex. The workload has changed dramatically now, and patients are discharged from hospital much earlier and not in a fully recovered position because of beds and politics. People are living longer with multiple illnesses, more care is being delivered at home, and community caseloads have increased exponentially. Recruitment is very fragmented, as nurses are now qualified, but there are no added post-registration training courses for them. There's modules, but they usually have to pay for those, but no free courses to enable you to develop your role. Experienced nurses are retiring, and the issue with traditional training and RNs retiring is we're losing a valuable resource. We're losing experience and patient-focused care. Vacancies are remaining unfulfilled because the pay is too low for the responsibility, and the disconnect from GPs now is huge. District nurses are covering massive geographical areas than they once did. And so when I hear that families are waiting up to 90 minutes, I think this is why. And I don't blame the nurses. This is the system. This is politics in the NHS. The nurses haven't changed. The workload and the acuity has, and the investment, I suspect, hasn't kept pace with demand. We all know community and social care is seen as something way down the line when it comes to money. But my concerns as a professional RN is, I understand why researchers are asking whether relatives can administer this medication if needed. But I also wonder, are we asking the wrong questions? The question shouldn't be, can relatives safely give diamorphine into the nose? The bigger question is, why are we needing them to? And one of the comments I made when reading the outline of this research was, If trained family members are administering controlled drugs, why have we got nurses? Now, let me explain what I mean by that. I'm not suggesting that nurses only give injections and that's all they're good for. Far from it. Nursing is very much more complex than that. But it's about assessment in the light of knowledge and experience. It's about observing and knowing your patient, knowing their history, knowing the way that they behave, clinical judgment, communication, comfort, the education that we're given when we're working in community, the support that we give to the families, the advocacy, but the biggest one for me is the ethics. Giving a spray into the nose takes seconds, and everything else that goes with it, that's nursing. So my concern isn't about whether we can train members of the public or relatives to learn a practical skill. What you can't teach the public to deal with is unwanted side effects, a response, and a demise, because patients can feel agitated before they die for many, many reasons, pain being one of them. And undoubtedly, my concern about the nurse's role is substitution. Are we gradually replacing professional nursing care with patients, relatives, and family responsibilities just because we don't have enough nurses available? Are we removing the humanity from caring for terminally ill patients? And I think that's a question worth asking. Now, because end of care isn't seen as an emergency, it is a vital and important stage of healthcare. It's one of the most dignified areas of nursing we can give to somebody who's leaving our planet. But each stage in the process needs and deserves consideration. Families deserve support, not a role. Patients deserve dignity. And no one should be spending their final hours waiting unnecessarily in pain and or agitation. And the researchers behind the INDIGO study deserve credit for trying to improve on that. But maybe improving end-of-life care isn't about new ways of delivering medication. It's about rebuilding the community nursing service that supported generations of families that have gone way before us. Or maybe the answer isn't either or, maybe it's a bit of both. Innovation, along with investment in district nursing and GP community services, is very specialist, and specialist nursing requires supporting patients and their families, not saddling them with a responsibility they're not really supposed to hold, even if they're given training for the sake of having trained, skilled, experienced staff. And I'd genuinely like to hear your thoughts on this, both as a member of the public or a family member who's been through this process before the INDIGO study or is actually taking part in the INDIGO study. So if your loved one is dying at home, would you feel comfortable administering intranasal diamorphine and midazolam by yourself at 2 a.m. despite training, or do you believe that responsibility should remain with trained nurses? As always, thank you for watching this video. I just needed you to know about this study and to highlight how care in the NHS is being fragmented off to families, and it's something as a nurse I'm getting to hear and see more and more of, and there will be more about this. As always, thank you so much for watching, and if you've enjoyed the video, don't forget to like, subscribe and share with everyone who's concerned about the future of our NHS. Until next time, you take care.